Good. Okay, Praveen.
Should I start, sir?
Yeah.
Sir, a 50-year-old gentleman, teacher by profession, presented with complaints of dilated veins in the right lower limb since 3 years, pain in the right lower limb since 1 year, and discoloration of skin over right ankle since 3 months. History of present illness. Patient was apparently normal 3 years back. Then he noticed dilated veins on inner aspect of right lower limb, insidious in onset, gradually progressing from ankle to mid thigh, which was increasing in size on prolonged standing or walking and was decreasing on lying down. It was associated with intermittent episodes of dull aching pain since 1 year in the right calf and lower leg, severe at end of the day, decreasing on lying down and elevation of limb. Also complaints of discoloration of skin or right ankle since 3 months, which was insidious onset, gradually progressing and not associated with itching. No history of edema of leg, no history of fever, no history of abdominal distension or chronic constipation, no history of breathlessness or cough or hemoptysis, no history of intermittent claudication, no similar complaints on other leg.
Wait.
Past
Go back. What is the relevance of abdominal distension, chronic constipation, cough, and hemoptysis?
Sir, abdominal distension and chronic constipation can cause secondary varicose veins, sir.
No,
So
but
to rule out it,
on only one side.
sir,
On only one side. If it is abdominal
yes,
cause, you should have bilateral, no?
sir, if it is on like pelvic tumor, sir, or due to chronic constipation on one side, and
See, how common is that? See, I think you should not unnecessarily, complicate things. I have never seen a varicose vein after, being in vascular surgery for so long due to something pressing on the vein and causing varicose veins. Varicose veins by per se is a very common problem. You have not spoken about present, history suggestive of deep vein thrombosis, which is much more relevant compared to this abdominal mass and hemoptysis and cough causing. What is the
yes,
significance of cough and hemoptysis?
sir, DVT causing pulmonary embolism, sir.
Then why not talk about DVT at itself?
Sir, I mentioned edema of leg and fever, sir. It is
No,
not associated.
that is not edema of the leg and you should very clearly say no history suggestive of deep vein thrombosis in the past. That is the word
Yes,
you have to use. Not just edema. Edema can be due to anything.
okay, sir.
And go to the next one. Next slide. No, why? No. Why no history of intermittent claudication?
Sir, patient did not have the history, sir. So to roll out the arterial causes, I have mentioned it, sir.
So you get dilated veins is the arterial cause.
No, sir, due to pain, sir. Yes, also complaining of pain at same, which was at the cough. So to rule out arterial cause, I have took history of such.
Again, I don't think it is relevant, but anyway. But can you differentiate? How can you differentiate with pain with neurogenic claudication, venous claudication, and arterial claudication?
Sir, in arterial claudication, pain starts after walking for a few distance. Then pain relieves on sitting down position or taking rest. But in in arterial, it will be of cramping pain. In venous claudication, it will be of bursting type of pain or dilating pain, which will be more severe at the end of the day, and it will be relieved by mostly by supine position and by elevation of limbs, sir. In neurogenic claudication, and first step itself, there will be eliciting of pain, and most probably at certain position of patient, uh, there will be pain, sir, and it will be relied on taking rest.
I don't know whether neurogenic claudication will go away by taking rest, because it can
By
be
changing that
present.
position, sir.
Yeah. Because even when patient is resting in the bed, you will have severe pain shooting down the leg.
Sir.
So I think, when you are dealing with the first primary complaint is dilated veins and then pain coming later, you don't need to talk about intermittent claudication, because it will unnecessarily, show that you are not actually. See, you have already examined the patient, right?
Yes, sir.
So, did you find anything to suggest that this is an arterial disorder?
No, sir.
So then why don't you edit it? I told you that, you are not presenting history in isolation, clinical examination in isolation. It is a combined. After history, you examine the patient and make a diagnosis. If the examiner is crazy enough to ask you, did you ask about arterial claudication? Then you can say, yes, sir, I did, and the patient did not have it. There ends the matter. But if there is a sane examiner like me, he will wonder, why have you asked about arterial claudication in this patient?
Okay, sir. Yes.
Nitya, Sharath, what do you think?
Yes, sir. So I have to unmute, sir.
Yeah. No,
Uh,
you are okay.
uh,
Talk.
uh, yes, sir. Same, sir. As you told, no need to describe about intermittent claudication in this case because they are explaining about dilated veins in the leg.
Yeah, first the patient is complained of dilated veins, pain came later. So this is
Yes, sir.
classical case of varicose veins. The
Hmm.
only history which actually was very significant, which you didn't mention, is presence of symptoms suggestive of deep vein thrombosis in that leg,
Hmm.
or history of trauma. Those are two important things that you should have mentioned. Nitya and Sanya, what do you think?
Agree with you, sir. He should have stuck to complaints regarding varicose veins only.
Niranjan is not there, no?
Sir told he'll join in 10 minutes, sir.
No, that's okay. No, why I'm not Kaiswan. I just want to know if he's there. I wanted to ask his opinion. That's all. Okay, Nitya. Nitya is not there.
She's
Hello.
there, sir. Nitya is there, sir.
Then why is she
She's
not
unmute.
answering? Nitya, unmute yourself.
She's unmuted herself, sir.
Then why is she not answering? Nikitha,
Yes, sir.
what do you think about the history?
Sir, I mean, from presenter's point of view, shouldn't we like look it as a peripheral venous vascular pathology also, sir? Or should we actually only go with the varicose veins? Is a confusion, sir.
No, there is no confusion. See, I have to keep telling you. Are you presenting the history, just history, and then going back and examining the patient? Tell
No,
No,
me.
sir.
sir.
No, sir.
No, sir.
No, sir.
Then see,
As a whole case together.
you take the history, then you examine the patient. As you are examining, if you have left out any questions, you can keep asking the patient as you are examining the patient. If you find any findings, let us say you found a scar, and then you can ask him, did you have any history of trauma which caused deep vein thrombosis? And then the leg became like this, and he started getting prominent veins in the leg, is swelling of the leg and things like that. So you keep taking the history as you go along as you examine the patient also. After you initially taken a history, if there are any lacunae in your history, you can fill it up as you go along. And once you finish examination, you have come to a conclusion whether this is an arterial disease or a venous disease or a mixed arteriovenous disease. So there is no confusion. You have already examined the patient, and there is no symptom. I hope that there are no signs suggestive of arterial disease. So in which case you should just stick to venous disease. If the examiner is very insistent on asking, did you take any history about claudication, you can then say, yes sir, I did, but there is no history suggestive of arterial claudication. That's all. So
Okay,
there is
sir.
no confusion.
Hello,
These
sir.
things
Can
are
you
all
hear
very
me, sir?
straightforward. Huh?
Hello, can you hear me, sir?
Yeah, Nitya.
Hello. Yeah, sir. I think my network was not good that time. My earphones were changed. That's why I would like to say the same thing, sir. Like, not to talk about artificial intelligence.
Okay. So Praveen,
Yes, sir.
you just stick to this one. So history of trauma, history of previous history suggestive of deep vein thrombosis. Those are the only two things you need to ask as
Okay,
far
sir.
as varicose veins are concerned. Anything else in the history? This one you have talked about he's a teacher, you said, no?
Yes, sir.
So profession where he stands for a long time.
Yes, sir.
Okay, right. Go to the
So, past
Ah.
history. No medical comorbidities, no previous surgeries for varicose veins, and no prolonged hospitalization and immobilization. Personal history takes mixed diet, normal sleep pattern, normal bowel and blood habits, no history of smoking or alcohol intake. Family
Okay.
history, no history of similar illness in family members.
Okay, examination.
On general examination, patient was conscious, oriented, moderately well nourished. No pallor, no icterus, no sinuses, no clubbing, no pedal edema, no general lymphadenopathy. Pulse rate 78 beats per minute. BP 130 by 70 mm of HG. Saturation 98% on volume and afebrile. Local examination. Patient was examined in a well-lit room under adequate exposure with both lower limbs exposed from umbilicus, both in standing and lying down position. Inspection on standing position. Attitude of limb was normal. Localized multiple dilated veins on right lower limb over lower one third of middle aspect of thigh, middle aspect of leg, and just below knee and over medial malleolus. There was discoloration of skin over medial malleolus. No ulcer or scar or scratch marks present. Saphenopharynx not present. Right lip appears to be normal.
First of eight. First of all, there is no limb length discrepancy. There is no discrepancy in the girth of the limb compared to its fellow. Is that not important?
Important, sir.
Second, you don't have to, you can say all these things, but you can say varicosities affecting the greater saphenous venous system of the left lower limb. You are now talking, you are not talking in patient's words, you are talking as a surgeon. So you can say, unless there is any doubts, you can say there are varicosities affecting the greater saphenous venous system. But are there varicosities in the short saphenous system?
No, sir.
So then why don't you describe it that way? Multiple varicosities, dilated veins affecting the greater saphenous vein.
Yes, sir.
And
Sir,
if at all, huh?
nothing, sir.
You wanted to say something?
Sir, girth, should we comment in the inspection or
Yeah, can you
palpation,
not
sir?
make out? Can you not make out? You can make out.
Appears
No,
to be, yes, sir.
on visit, see, there may be sometimes very subtle difference, which you can then say after measuring that there is no. See, the things are important if you are thinking about, arteriovenous malformation and things like that. Or if the patient has suffered deep vein thrombosis in the past. And why is that important, Nikitha? Let us say patient has developed varicosities after suffering deep vein thrombosis. Why is that important?
Uh, Recurrence of the deep vein thrombosis, sir.
Not recurrence. Praveen, let us ask Praveen only. Praveen, patient has come to you. He has had previous DVT and now he has varicose veins. Why is it relevant? Why is it important? Ainas, Samir, Ainas, any one of you?
So,
Sir, that will indicate post-thrombotic syndrome, sir.
Yeah. So what is its relevance?
So, it tells that there is a damage to the deep vein itself, sir. So there is chronic venous
Yeah, I understood. Yeah, that is
Yes.
post-thrombotic. Everybody understood what it is. So what is the relevance of that?
In case if you are planning a surgery, he's already on DVT, like blood thinner, sir. With that relevance, sir.
so you don't do stripping in these patients, sir.
Operate on these people.
Should not
Yeah.
operate.
Don't operate on these people because the deep vein is gone, and hence these superficial veins have become, they are the
Sorry.
only venous drainage of the leg. So forget about stripping. You don't operate. Nikitha, what are you talking about? This one, blood thinners and all that. You don't operate on these people. Okay,
Okay.
right. That is the relevance. So you should say, limb length discrepancy, girth discrepancy. Then, as I think Praveen mentioned, the varicose veins, he described it. Instead of that, he can say varicosity is affecting the system. And then he is mentioned about no evidence of ulcers. You can say no no on inspection, there is no evidence of eczema, lipodermatosclerosis, or venous ulceration. You can say all these things boldly because
Okay, sir.
this is now your, as a surgeon, you are presenting. Sharath, what do you think?
Yes, sir. And you can tell about no skin changes, sir. He's having only discoloration of the skin.
Yeah.
Okay. Only skin change. Only one changes is there. Yes, sir. Okay, sir.
Okay.
That's okay.
Continue, man. Continue.
Yes, sir.
Yes, sir. On inspection on lying down position after limb elevation, there was collapse of veins were noted. On palpation, no local rise of temperature or dilated veins, no tenderness, no thickening of skin, no pitting edema, no palpable inguinal lymph nodes on both sides. On
Okay.
Brody Tunderland bulk test, it was positive and positive, suggesting of saphenofemoral junction incompetence and perforator incompetence. On multiple tourniquet test, there was incompetence of aboni, below-knee, and lower leg perforators. On modified Perthes test, there was no pain and there was decrease in varicosities, suggesting there was no DVT. On squash test, impulse was felt at saphenous opening. On Morris's cough impulse test, expansile cough impulse was felt at SFJ, suggesting of incompetence. On Figen's method, depressions were felt at above knee, below knee, and lower leg perforator sites. On percussion,
So all
squats test.
tests are positive.
Yes, sir.
This is an imaginary case, right?
Sir? No, sir, it
This
was
is
old case, sir.
Okay, right. You have already, this is the real patient.
Real patient, but old case, sir. Yes, sir.
That's okay. That's okay. Anytime you take. What about the right lower limb?
Sir, this is right lower limb, sir. Next
Ah.
time, telling, sir. On
Yeah.
percussion, squash test positive. Auscultation, no murmur said. Left lower limb is normal. No palpable inguinal lymph nodes on both sides. All arterial pulsations present on both lower limbs. Sensory was intact. Joint movements was normal. And power was 5/5 on both lower limbs. On systemic examination, per abdomen, no distension, no organomegaly, no palpable mass, and bowel sense were had. Serious S1, S2 had no murmurs. Respiratory system, bilateral normal vascular bed sounds. CNS, no focal neurological deficits.
Okay. So what's your diagnosis?
So my professional diagnosis will be of varicose vein in right lower limb of primary etiology involving great saphenous vein with saphenofemoral incompetence and above knee, below knee, and lower leg perforator incompetence. So my CEAP classification will be of C4A, EP, means E primary, A is anatomical suggestive of superficial veins and perforator involving, and pathology of reflex.
Okay. Right. Now, how will you Confirm
Sir,
your diagnosis.
one doubt, sir.
Yeah.
According to old CEP classification, this one was here, sir. C4A, AP, ASP, and PR. Then later after 2020 modification, according to it, this will be the classification, sir. Should I mention the old one or new one, sir?
They mention the new one only.
Okay, sir.
If the examiner is not up to date with the new one, then if they ask you, then you can say, sir, this is a new classification, but according to the old classification, this is what it is.
Okay,
Just
sir.
in your mind, when you write it up, write this. But if in your mind, think about what it would be if the old classification. That's all.
Okay,
I
sir.
don't think they will ask you. Okay. How will you go about managing this patient?
Sir, to confirm the diagnosis, I'd like to do a duplex imaging along with
Venous,
getting, sir.
venous Doppler.
Yes, sir. Venous Doppler of left lower limb, sir.
Do
Sorry,
you
right
need
lower limb, sir.
duplex for this? Do you need
Sir?
duplex for this?
Sir, yes, sir.
Why?
Sir, in the duplex, you can see the reversal of flow, sir, which is it suggests varicose incompetence. If there is reversal flow of 0.5 seconds at SFJ, then it suggests of SFJ incompetence. If it is greater than 0.35 seconds at the perforator, along with 3.5 mm defective fasciolator, then it suggests perforator incompetence, sir.
Okay. So, so you've done the Doppler, venous Doppler or venous duplex. Mention, don't say just the duplex scanning. You should say venous duplex.
Yes, sir.
Okay, because you
Excellent.
you're not
Duplex
doing
imaging of
RTPA.
venous system. Yes, sir.
Yeah. Okay. Now it confirms your clinical diagnosis because this is an obvious SFJ incompetence with perforator incompetence. So how will you manage this patient?
Sir, initially we'll start with conservative management, sir. With
Why?
use of,
How
sir,
old is he?
50 years, sir.
Why are you managing him conservatively?
Sir, with adjunctive
Got pain
managements,
for
compression
two.
hormones.
He's got pain for 2 years. He's got varicose veins for the last 2 years and pain for the last year. And he is 50, and he's got no comorbidities. He's presumably fit for surgery. So why are you denying him surgery by offering him conservative treatment?
Sir, if he's not responding, then we can proceed to the surgical
I
management.
think this is a case where things will only get worse. He's already now got discoloration. In future, he will develop venous ulceration, lipodermatosclerosis, and all those eczema and things like that.
Yes,
So you
sir.
want him to develop all the complications before you offer him surgery?
No, sir.
See, I don't think just because somebody has come and you always have to manage things first conservatively. If somebody comes to you with the colon cancer, will you say I'll just first conservatively treat him, give him laxatives and see how he goes, then we will think about surgery later?
No, sir.
See, for example, you detect inguinal hernia in somebody who is totally asymptomatic, and patient has access to medical healthcare, because he lives in a very good area, and if at all he is reluctant to get operated, then you can say we'll manage it till such time you start getting symptoms, where the symptoms are unlikely to be very serious, and you can tell him that if at all you suddenly develop severe pain or whatever, you give me a ring and come into the hospital, because at least even if it is obstruction, you can prevent strangulation. But here, I don't see any reason why you should manage this conservatively. Sharad?
Yes, sir. We'll go. That's what he's already having skin changes, pain, edema is there.
Correct. So, patient is symptomatic. It's not incidentally detected varicose veins. Praveen.
Yes, sir.
So, why are you offering? You should be very clear in your mind. If, for example, you detected varicose veins when he came for investigation of something else, and patient is totally asymptomatic and is reluctant to get operated, then you can say we'll I would have still offered surgery, but patient is reluctant, so I've given him conservative treatment and told him if these things happen, come back, seek medical attention. But here he has already sought medical attention for this problem. He's become symptomatic. So, Nitya, what do you think?
Correct, sir. We should go ahead with surgery.
So, Praveen, don't get into
Yes, sir.
unnecessary trouble. It is
Yes, sir.
nobody will
Understood,
think
sir.
you are smart just because you have offered conservative treatment. Conservative treatment, it has a role in certain situations, but if the patient is elderly, 80 years of age, and not very mobile, no point in offering him surgery. But if he is symptomatic, you still have to offer him some form of treatment, or you can give them compression stockings and see whether he responds to that. And if he doesn't, within 3 months or 6 months, then I think laser surgery can be done fairly safely. So you can offer laser or radio frequency ablation or something like that. So don't get into trouble by saying conservative treatment. Okay.
Yes.
So now how will you manage this patient? I'll ask you this.
So,
Repeat the question.
I'll plan for the procedure of saphenofemoral flesh ligation and stripping of great saphenous vein up to upper calf and ligation of above knee, below knee, and lower leg perforators.
Okay. Why not the newer modalities of treatment? Why do you go for standard surgical treatment? Why not go for any of the newer methods, either laser or radio frequency ablation?
Yes, based on surgeons' competence and compared to standard and laser ablations, standard one there has less recurrence rates comparatively.
Are you sure about this?
Yes, sir.
Quote the literature to me, because
Yes.
as of now, all the results, even I think fairly long-term results, 10-year results have shown that they are equivalent in terms of recurrence and things like that. You can check with that is why I wanted Shravan to be here, because we are not in this field for a long time now. So what we know is what we have read, but latest this one. Sanya, Nitya, or Nikita, have you any one of you read to confirm what Praveen is saying?
The article which I have read, the meta-analysis and everything, they have commented that both of them are equivalent, sir, as of now.
Correct. I think, and they have now 10-year results
Yes, sir.
of laser ablation. Yeah, laser. Which is better, laser ablation or radio frequency ablation?
Radio frequency
Or
ablation, sir.
gel, this one, gel foam injection?
Sclerotherapy.
Home
It is
Sclerotherapy.
Yes,
reticular.
sir. Radio frequency ablation has high. It has high effective, sir.
No, you have to give me figures. You
Sir,
can't just say
in radio,
something.
yes, sir, in radio frequency ablation, there is almost 98 to 99% of occlusion, sir. There is complete occlusion. In endovenous laser ablation, it ranges from 77% to 90%, sir, over 6 months
Okay.
of
What
occlusion.
about what sclerotherapy? Sclerotherapy for smaller veins,
Yes, sir.
not for major.
Major venous
Sys-
system, yes, sir.
Okay. So then why not do radio frequency ablation? Why are you opting for surgery?
So we can do with radio frequency ablation, sir, based on.
See, Praveen, you should not get into this kind of situation. You should say boldly, I will offer all of these methods to the patient, and I will give him all the figures about the recurrence rates and complications and cost and everything, and he can choose whichever he wants to choose. And I will go by patient's choice based on my, whatever explanation I have given.
Yes, sir.
If the patient says, I want to get operated, then you operate on the patient.
Okay, sir.
Despite you having told him all these things, the newer methods and everything. See, definitely um, if the rates are, similar in terms of recurrence, I think, if you do the surgery well, I think previously there used to be a bloodbath with varicose vein surgery, which is not there anymore. I have not seen any, and I have done a lot of varicose vein surgeries, and we've not had much bleeding. But it can, lead to scar and things like that, and which can be avoided by, using either radio frequency or laser. This
Yes,
is
sir.
why what are the advantages of the modern methods compared to the surgical method? Does the radio frequency ablation and laser, does it need surgery? This one anesthesia, or can be done under local?
Sir, it can be done under regional or local anesthesia, sir. We'll use the tumescence anesthesia, sir.
Tumescence anesthesia. So you can avoid, no, but I think it can be done under spinal also, no?
Yes, sir.
So there is no difference in terms of anesthesia. Okay. What about other advantages of the newer methodology compared to the surgery? Anyone? Sanya, Nitya, Nikitha?
Post-op recovery, sir.
Ah,
In comparison, pain is relatively less in the radio ablation and laser.
I have not, had many patients complaining of pain. I've sent them all home next day, and I've not put them on any major painkillers, and they have not come back to me after a week and said I was in severe pain. I think even if you look at the literature, I don't think there is any major difference in terms of pain if you do visual analog scale between all the three of them.
Cosmetic would be.
Cosmetic, has anyone compared cosmesis using cosmesis course? See, this is, I am not up to date about these small details of the newer methodology compared to surgery. So this is why we wanted Shravan, because he would have probably told, enlightened us about this. And unfortunately, none of you have made an effort to read up about these things. So let us, Praveen,
Yes, sir.
let us assume that you are operating on this patient. Describe to me how you operate on this patient.
Sir, by radio frequency ablation,
Forget
I'll
radio
be
frequency
starting.
ablation. Okay, first describe to me how you operate on this patient, then we'll talk about radio frequency ablation or laser for that matter. Tell me how you operate.
First, I'll explain the patient about the different procedures available.
No, all that
is
is done. So
Yes.
all that is done. We have taken consent, patient is admitted, patient is now under anesthesia, he's already been given spinal anesthesia. So now you are operating. Tell me how you operate.
Sir, in radio frequency, in each method, sir.
No. First,
No,
I told you
surgery.
surgery.
Open
You talked
surgery.
about surgery, no? Why
Yes,
are you
sir.
going to radio frequency ablation? How
Sir,
many times?
I-
See, this is the problem. You need to understand the question. You first said surgery, and now you are again going back to radio frequency ablation. Tell me about surgery first.
Yes, sir. Patient will be in Trendelenburg position after regional anesthesia or local anesthesia. Then,
Why general position?
sir, to
Why general?
sir, to empty the veins, sir.
No, that it doesn't matter whether you empty the veins or not. You are operating on the patient. Only when you are testing, you need all that position. Patient will be in just supine position. Why does he need Trendelenburg position? No.
Sir.
Is it described in textbook?
Sir, in one of the books I read it, sir. So,
Nitya, Sanya, has anyone said you have to operate in Trendelenburg position?
No, sir. Supine position only.
Yes, supine position, man. I have never put anybody on Trendelenburg position. Okay. So, okay, patient is in supine position. What will you do? Where will you make the incision?
sir,
See, the thing is,
two point,
in the textbook, whatever they have described, you please describe. Basically they say, where is the saphenofemoral junction?
sir,
In the
3.5 centimeters below and lateral to pubic tubercle, sir. This
Okay.
point of saphenofemoral junction. So we'll be taking an oblique incision, sir, at that point. And
See, that is a classical teaching. But having worked in vascular departments in two big vascular surgery departments, we always used to make the incision above the groin crease, and almost always we used to be bang on onto the saphenofemoral junction, onto the cribriform fossa, where the saphenous vein dips into join the
to
femoral
join the
vein.
femoral vein, yes, sir.
So because when you are bang on that, you will never miss any of the tributaries, and also the small artery that runs there, you will not damage it. But unfortunately, all textbooks mention that you have to make the incision below the 3 point, as you said, 3.5 centimeters below. So that is what you should say. But when you are practicing, I'm telling you, if you are doing surgery, you will thank me if you go above the groin crease, about 1 or 2 centimeters above the groin crease, where when you feel the femoral artery. Is the femoral vein medial or lateral to the artery? Nikita?
Medial to the artery, sir.
When if at all you are asked to do a femoral tap because you are not getting any blood anywhere, how will you do the femoral tap? You are not getting all the things. Palpate the?
Femoral artery, sir. We palpate the femoral artery.
Okay.
And
and go medial to it. It's simple, man. There is nothing very complicated about it. So go medial to it. You will usually find the femoral vein. Okay, so the femoral vein will be medial to the femoral artery. Okay.
Then we have to identify the saphenous opening, sir, at the deep fascia. Then this we should expose the great saphenous vein that is piercing the cribriform fascia. Then we should follow it till the junction with femoral vein, sir, SFG junction. Then we have to flush ligate the great saphenous vein.
No, ligate the named. What are the named branches first?
Tributaries, sir. Yes, sir. Should identify the tributaries and should I ligate it individually. Those are all superficial circumflex iliac artery, superficial epigastric veins, superficial circumflex iliac vein, superficial epigastric vein, and superficial external pudendal vein, sir.
So, and then there will be several others. These are the three named ones. So one of the commonest causes for recurrence is that you are not identifying all the branches, which is why the incision, all vascular surgeons make incisions higher up, because you will not miss any of the branches. So that's important. So ligate all the branches, then identify the thing, and flush ligate the saphenous vein at the saphenofemoral junction. Okay, then other thing is, important thing is to also identify usually the posteromedial vein that comes.
Yes,
and
posteromedial and anterolateral axillary veins.
Veins. Okay. Then what do you do after that? You have already ligated and you have cut the junction. So now what do you do?
Sir,
Do you pass the stripper from below or from above?
Sir, go to below, sir. First we have to First, we have to mobilize the saphenous opening till 10 to 15 centimeters distally, sir.
What?
Sir, after ligation, we have to expose the GSV 10 to 15 centimeters distally, sir, to identify this posterior medial vein and anterior axial vein, sir.
See, the
Then,
thing is, it is not necessary to always identify them, because when you strip it, you will have, they will get, torn away. So it's okay. If you are going to strip it, it's fine. You can also, if there is already an obvious big vein in that region, then you have to make the incision and, ligate it. But it is not usually described. So you
okay, sir.
then come to the femoral, the saphenous vein just below the knee. Don't go too far down. What happens if you go too far down?
We will be injuring the saphenous nerves.
Nerve. So that is why just
Should
below the
be,
knee,
yes, sir,
there are
till the
two
upper
types of
cuff.
strippers. What are so you can strip it
So,
from either above to above, below, or from below upwards. There is something called pin strippers, which will
yes, sir.
invert, and then you can do both of them, but you just stick to one method. Usually what is described is to from below upwards. So you pass the stripper from where you have identified the saphenous vein in just below the knee, ligate the distal end, and then pass the stripper upwards till it emerges out of the saphenous vein in the groin, and then after you have dealt with the perforators, you then strip, because stripping is the last thing you do, because then immediately after stripping you should have also kept your sutures ready in the groin, so that as soon as you have done the stripping, you apply compression bandage. Otherwise there will be bleeding, and then the patient will have a lot of ecchymosis and sometimes even hematoma formation. So as you are stripping, you have to apply compression bandage. Otherwise,
yes,
you can develop hematoma. Sometimes the skin, there is a lot of bleeding into the skin, which will appear to be, ecchymotic patches, large ecchymotic patches, which will linger forever, and patient will curse you, especially if she is a pretty woman. So you have to ensure that you have done the stripping. You have done the stripping last, after you have dealt with the perforators. After you have, perforators can be dealt with by what method do you use for perforators?
sir.
Ideally,
We can will be giving a small incision and will be phlebectomy hook. We'll be using the phlebectomy hook and will be
say ideally
ligating.
what you should say is, I will mark the perforators, by Doppler
Yes,
on the day of surgery, so that you can. Then there, what is the other method? That is one, phlebectomy using hook, phlebectomy hook. That is
yes,
one. What is
yes,
called
sir.
as? What is the other method?
Other one is latest method, sir. SEPS,
What is
subfacial
that?
endovenous, subfacial endoscopic perforator surgery, sir.
Correct. So you should know about that also.
Yes,
So
sir.
you should you what you do is put the scope and go
Yes, sir.
past,
In the subfacial
identify
plane, will be
the,
placed.
yeah, just go past the in the subfacial plane and ligate the
Perforators.
perforators.
Yes, sir.
So you do all of that and then do the stripping last. So
Yes, sir.
remember that.
Yes,
Okay.
sir.
So right. So you have done, and then as I said, you have to apply compression bandage all the way up. And how long do you keep the compression bandage?
Sir, 4 weeks,
At
sir.
least, no, not 4 weeks. Anybody else?
1 week, sir.
Correct. 1 week. Patient comes to you for follow-up. You take away the compression bandage and apply the stockings. The stockings should be there for a period of post-surgery for how long? Raveen. Anybody else?
6 weeks, minimum, and continuation also, sir. Actually.
Minimum 6 weeks is correct, but preferably 3 months. So that will give you the best results. So you take away the elastic this one crepe bandage after a week and apply it. Ensure that you inspect all the wounds and make sure they are all fine. And most of the time you would have put subcuticular sutures for the groin, and other places you would have just put steri strips. Usually you don't need to suture them unless the below knee wound, also you have sutured, you have to inspect that also. But generally you put either subcuticular stitches, or if you put stitches, you remove them and then ask them to apply the TED stockings. That is for a period of, is preferably for 3 months. 6 weeks is also acceptable. So you should know all these things, post-op care and all those things.
Yes.
Okay, now describe to me the method of either radio frequency ablation or
Yes, sir. In radio frequency ablation, we'll be doing under regional general anesthesia. Preoperatively, we'll be doing our intraoperative mapping of varicose veins by duplex cancer.
yeah.
Then, patient is placed in reverse Trendelenburg position for cannulating the varicose vein. After cannulating, then we'll place the patient back to Trendelenburg position. Then a guide wire is passed. Through the guide wire, we'll be passing the radio frequency catheter, and which will be attached to radio frequency generator, sir. So this radio frequency generator produces causes the thermal ablation of that endothelial lining and causes fibrosis, sir. So
Okay.
it will target temperature will be of 120 degrees Celsius.
So to prevent the damage, what will you give?
We'll be giving the tumescent anesthesia, sir. It is a
Tumescent.
combination
It's not tumescent, it's tumescent.
tumescent, yes, sir.
Tumescent anesthesia with what?
It will be a composition of ringus lactate, 1% lidocaine with epinephrine and sodium bicarbonate, sir.
Okay, right.
So it will be given 10 ml per centimeter of veins.
Okay. So then
s-
how do you do the radio frequency ablation? Till what level do you go?
In both the procedures, we should go, the catheter tip should be 2 centimeter distal to saphenofemoral section, sir.
Okay.
So same in intravenous laser surgery as well, will be using the tumescent anesthesia.
Correct.
And will be preoperatively mapping, and will be passing the guide wire, and through guide wire will be passing the microsheath. Then the laser used will be diode laser of 1470 nanometer wavelength. So once same once
What is
from
the
will
time?
be
What is the time taken between, is there
sir,
any
will be
specific time?
yes, sir. From the tip we have to pull the retrograde slowly of 1 to 3 mm per second, sir. So
Both in
around sir,
RFA and in laser is the same?
no, sir. Only in the laser we have to do that pullback procedure, sir. RFA not required, sir.
You just pull it out.
Yes, sir. In laser, I have to pull back, and it gives it should deliver around 60 to 100 joules per centimeter, sir.
Okay. And what are the post-operative, what shall we say, instructions and for both RFA and laser?
Sir,
Any,
yes, sir.
any specific?
In both, immediately I have to apply external compression, sir,
Okay.
so that vein remains vein walls
Compressed.
get compressed, yes, sir.
Okay. And patients can be discharged next day in all the procedures?
Yes, sir. Can be done, sir.
Okay.
Praveen, any other newer
Sir.
technique?
Sir,
Hello, Niranjan.
ಹಾಯ್ ಸರ್ ಅವಾಗಲೇ ಜಾಯ್ನ್ ಆಗಿದ್ದೆ ಬಟ್ ಸುಮ್ಮನೆ ಕೇಳಿಸ್ಕೊಂತಾ ಇದ್ದೆ ಏನ್ ಇದಿರ್ಲಿಲ್ಲ ಅಡಿಷನಲ್
Any one change or any advances?
ಅದೇ there is something called as same like laser nowadays they are doing glue therapy. glue,
endovenous glue
endovenous
therapy you can use, sir.
glue therapy. That is what I also don't know the results of it, but I've seen many people doing it. So that's why Shravan, if it was there, it would have been better. So, so endovenous glue therapy, but what I've heard is it is very costly and some 2 lakhs or 2.5 lakhs it will cost. So you have gone through the literature, Praveen?
It has newer modality, sir, but it has recanalization rates are higher, sir, around 50 to 60% in 3 months, sir.
Okay. Because that is the newer procedure which even like so many of interventional radiologists have started doing.
Niranjan, what about the results of standard surgery compared to the newer modalities?
Current, I think current evidence as of now is the laser has become the standard of care kind of a thing, until and unless it's a tortuous vein or a very large vein with a bunch of varicosities, one adjacent to each other and all those things. If current standard of care is probably the laser therapy. That is what I had read and also heard Vivekanand sir say and also Shravan say. So RFA and all those things are newer modalities, probably case to case basis and also surgeon to surgeon basis. I don't think there is any long term evidence with respect to endovascular glue therapy, but those are the newer modalities, but they are probably lesser invasive when compared to laser and RFA. And side effects, I think recanalization rates are still probably 5 to 10% in laser. That is what I think literature says also. Praveen?
Yes, sir.
So current standard of care is laser.
Yeah, Praveen, what is the recurrence rates for after surgery? Nikitha, what are recurrence rates after surgery? Anybody? Nithya, Sanya, anybody? Golden silence. Is it because you don't know, or is I think it's a stupid question.
Sir, it depends on the type of surgery also, sir.
No, standard surgery, sir, asked. No. What is standard procedure? What is the standard surgery?
Stripping and ligation, sir. Conventional standard.
Trendelenburg operation.
Trendelenburg, sir. Yes.
So, what is the recurrence rate after that as per literature? That is what sir is asking.
30 to 40% after 5 years, sir.
Oh my God.
Too high, too high. See, problem with stripping is it's not the recurrence. Recurrence rates are, I think, maybe 5% or maximum a little bit more than that. Hello, sir?
5 to 10 maximum.
5 to 10 maximum. The problem with open surgery was one, the wound and the scars and also the probable slow recovery. That is why the laser has come into picture. Apart from that rate, recurrences are lesser than any of these newer procedures with open surgery.
See, that is why I think Praveen, when you said venous hooks, so there are actually, I don't know whether they are using it now. In England, I used to use, there is a special knife that comes with the hook. It is so small, the stab is very, very small. And the hook is able to go through that, and then you pick up these veins and then you do the stripping of these veins. And basically, cosmesis also, many of the young women whom we used to do would never complain about cosmesis because I think it would heal very well. But I think obviously the newer methods have come and they have. I think Niranjan is right. I don't know. Praveen, is there long-term results for RFU or RFA? 10 year?
Sir. 10 year, I didn't. It's a 5
I
years.
think laser they may have it for 10 years.
10 years.
RFA, I don't think so. RFA, I don't think so. This is 10-year data.
10 year illa. So I think Praveen, the lot of things that you have to, take care of in the history, some of the, as we mentioned, all of that. And in the examination, I think it was fine, but you can straight away say varicosity is affecting the system, whichever system that you think it is. And you can also then later say there is no evidence of deep vein thrombosis based on your examination. And then when you are asked about treatment, you said, I will offer conservative treatment. I will not accept that. It will be a major cross for you. So you have to justify why you are doing it. Okay, so don't say I will not operate. Patient is symptomatic, he's come to you to the hospital with pain and with long-standing varicosities. Why are you conservatively treating him? You
And
should not
also,
say that.
you yourself have told that it is progressively increasing and symptoms are increasing. So
Yes, sir.
when patient has come to the hospital, if you say conservative treatment, then you will fail in the exam. He
Yes,
has
sir.
come seeking treatment for his symptoms already, and it is going on for 3 years now.
And it is not incidentally picked up, nor is he very old that say he's a high risk for surgery. So there is no role for conservative treatment. Okay, don't say
Yes.
make such mistakes.
Yes, sir.
Okay,
Yes, sir.
nobody will think you are a smart guy if you say that.
Yes, sir.
Okay, and when it comes to treatment, you said you will go for surgery. Again, why surgery? You should be able to justify it, especially if you have all modalities. You should say why you are offering surgery. If, for example, if these varicose veins are extremely huge, and Niranjan said, huge bunches, side by side to each other, which is unlikely to be well treated by laser, you should straight away go for either laser or radio frequency ablation at the present time. Especially if the patient can afford it, and if all things being equal, you should offer laser or radio frequency ablation. Surgery, you should have very specific reason why you are operating on
And
a
also,
particular.
probably you can add injection sclerotherapy there to the
Yes,
to this one perforator area or the side branches and all those things.
yes, sir.
Okay.
Yes, sir.
So time is up. Nikitha, what did you think of his presentation? Comments by Nikitha first, and then by either Sania or Nitya. Quickly.
Sir, clinical presentation was good, sir, but the stand to take on the management was the only thing which we are uh, little hesitant about, sir. Other than that, clinical presentation,
You,
history-wise and examination was fine, sir.
so no, again, history-wise also, I've told you what are the things he missed.
Yes, sir.
So
Yes,
there's
sir.
no need to sugarcoat it. No, you should tell it as it is, because this is a forum where he can correct himself. We're not trying to just pat him on his back. Nitya,
Sir, I think the more he presents, better it will become, sir, for him. Because
but
after a
he has got only 5-10 days now left.
yes, yes, sir, yes, sir. I think one more varicose presentation needs to be done, sir, with
Not,
Shravan, sir. With Shravan, sir,
yeah.
to be.
So Praveen, you should go and present the same case to Shravan. Okay.
Yes, sir. Yes, sir.
Okay. Right. Sharath, your
So
comments.
it's okay, sir. Presentation was good. The treatment wise, that's what. It little hesitant to explain everything. Indications, contraindications, about the endovenous laser therapy, radio frequency ablation,
Niranjan, final
surgery.
comment.
Sir, that is what I think. If Dr. Shravan would have been there, it would have been more useful. We would have completed the entire thing today.
Yeah.
Otherwise, it was okay.
Okay. So Praveen, you presented well. There is good flow. Your knowledge is pretty decent. It's just that you should know how to, manage it well. Because, for example, you should very specifically mention no history suggestive of deep vein thrombosis in the past. That is one, no history of trauma. You missed those two.
Yes,
And
sir.
when it comes to examination, I think you should straight away say that it is which system is affected, and then presence of DVT or not. And then in terms of treatment, as you should offer surgery straight away. and then the modalities you can say, I will explain all the modalities currently available to the patient, and you will go by the choice of the patient. That is acceptable answer. Okay.
And
Yes, sir.
also depending on where you are giving exam, so always don't straight away jump and say that I will offer laser surgery. Okay.
Okay.
So
Yeah,
you
that's
can say you just say that, sir, for this patient there are two options. One is conventional surgery and the laser surgery based on the expertise and the patient this thing request. So don't straight away jump for laser surgery, although it is a
laser.
standard of care now, because some of the medical college examiners may not like it. They
Yeah.
still probably would prefer you to say classical Trendelenburg operation. So you don't commit to either of it. Just say both the options are available, and I'll leave it to the expertise if the expertise available, and also the patient's demand.
Yes, sir.
Okay. Yeah. Okay. But it's been presented well, Praveen. Don't worry. Just go through the clinical methods properly. Make sure that you have not missed any findings. Okay. For all
Yes,
of the standard cases, practice and practice. For the next 10 days, don't read much theory. Just go through the clinical methods. For thyroid, for breast, for abdominal mass, for hernias, varicose veins, and this one. What else is there? Anything
peripheral
else?
artery diseases.
Peripheral artery disease.
Peripheral arterial disease. So all of these, every day go through the clinical methods. Make sure you have a pattern of presenting so that you will not miss any findings. Okay.
Yes, sir. Yes.
From now on, that is what you should do. Okay. What you can
Yes.
do is this week another presentation. If you want to have, you can have. Okay.
Yes, sir.
Right.
Yes.
Good night.
Thank you, sir.
Good night, everybody.
Good
Thank
night.
you.
Good night, sir.